The case that is a postgraduate student, a 23 years old lady, 15 days of breathlessness, worsened since 2 days. She came to us with hemoptysis and right-sided chest pain. She had a recent COVID a year back, and her saturation was 70% on room air. Her BP was 80/70 despite medications. So she fitted into high-risk pulmonary embolism. ECG showed sinus tachycardia. The expected S1Q3T3 was not there, but however, an S1 was there. I always find that the depth of the S1 helps us to assess the benefit of reperfusion in acute pulmonary embolism. And this is the ECG, shows the dilated RA and RV. The McConnell sign was there, and a D-shaped LV with an adequate LV function. So we proceeded with, there was a clot in the right pulmonary artery. Though CTPA was done, we could diagnose it with the echocardiogram itself. So CTPA shows again right descending RPA bifurcation pulmonary artery thrombus, the posterior medial segments lobar infarct. So which category does this belong to? According to the American Heart Association category, it is a massive pulmonary embolism, and then European Society of Cardiology, it belongs to a high-risk pulmonary embolism. Now, this is the classification that we use. The original AHA used to classify as high-risk and submassive pulmonary embolism. But however, we found that there are subgroups within the submassive pulmonary embolism, and that is the reason European Society of Cardiology came out with the intermediate high risk and the intermediate low risk. But all these groups are stable only. The only thing is the abnormality of imaging in the echocardiography or other imaging and elevation of cardiac biomarkers. If both these are there, it becomes intermediate high risk. Otherwise, it's an intermediate low risk. Now, our patient belonged to a high-risk pulmonary embolism or a massive pulmonary embolism. This is just one of our observations we present the European Society of Cardiology, Barcelona, the largest single-center study in India, prospective study, 186 patients. We found that the sinus tachycardia was the commonest finding, and S1Q3T3 was there only in about 56% of the patients. In the echocardiography, RV dilatation, RA dilatation, and RV dysfunction are commonly found. This patient had all these changes except S1Q3T3. What really happens in high-risk pulmonary embolism? So, because of the lot of stuff happening. In addition to the mechanical obstruction, it is a neurohumoral activation, it is a myocardial inflammation, and intrapulmonary AV shunting. All these take place. Our treatment needs to take care of all these areas so that we can help the patient to recover without issues. Now, what did we do? We gave immediately intravenous heparin as soon as the diagnosis was suspected. That has been always our protocol. And we started thrombolytic therapy with the streptokinase, and we continued for 48 hours. And we also supported the patient noradrenaline and dobutamine. We ventilated initially with CPAP, and then we had to uptitrate to mechanical ventilation. Clinical iteration, we lost the patient on day 9. A young girl dying of acute pulmonary embolism despite maximal therapy given at the time of onset. So let us see what is we can learn in this patient. We always advise starting anticoagulants at the earliest, even before diagnosis, when a high-risk pulmonary embolism is suspected. Studies have been done on that and shown that starting anticoagulation early improves survival. So what are the anticoagulation agents? Commonly low molecular weight heparin and fondaparinux are weight adjusted used, but we use unfractioned heparin because it becomes much easier to uptitrate to the next level of therapy in case the patient requires a catheter-based lysis or a surgery. Otherwise, Dovax monotherapy for low risk and intermediate low risk pulmonary embolism. So what is the hemodynamic support? Our target is to reduce the RV afterload, improve RV contractility, and maintain systemic perfusion. What did we do? We started dobutamine in view of RV dysfunction. However, dobutamine is already going to compromise the systemic perfusion. So we started norepinephrine to maintain a MAP more than 65. And why did we do this? I think I already told you. This is the reason. And we always give IV fluids if the IVC size is less than 15 millimeter. Whenever it is more than 15 millimeter, we need to be extra careful because this can worsen the septal push on the other side, and it can compromise already compromised cardiac output. We need to be watchful when we are pushing in IV fluids. And role of oxygenation, we give hypoxemia as managed, but then mechanical ventilation, whenever possible, we can avoid. But in this patient, we could not avoid because mechanical ventilation is going to increase RV afterload, reduces the venous return, and in case we need to do mechanical ventilation, we need to use hemodynamically neutral agents for induction. You can avoid propofol. So systemic fibrinolysis, we always use fibrinolysis in high-risk acute pulmonary embolism. Streptokinase, urokinase, and alteplase are the approved pulmonary thrombolytic agents by FDA. Other two are not yet approved, but however, data has been good. And the response timing, usually it takes place in the first 36 hours. And the greatest benefit comes within 48 hours if we lyse early, though benefit can come up to 6 to 14 days. Well, the bleeding is always there. Intermediate risk pulmonary embolism, well, we lysed about, we had 90 patients in our study of intermediate risk pulmonary embolism. We lysed almost 42 of them, but then we did not find a statistically significant benefit of lysis in the intermediate subgroup in our patients as well. The same thing has been replicated in multiple studies also. So this is a study just to show that, the timing of lysis in pulmonary embolism. The patient comes early and presents early. The study shows that the angiographic improvement was better, the scintigraphic improvement was better. So whenever the patient comes early, the benefit is better. Unfortunately, our patient came after 6 days and since the benefit was suboptimal. So this is the European Society recommendations. In fact, class 1B systemic thrombolytic therapy based on the UPET study which did not show mortality benefit, and another 16 patient study in which all the 8 patients who were not lysed died and all the 7 of the 8 patients who were lysed survived. These are the only randomized data available in lysis in high-risk pulmonary embolism, and based on that, now it is a class 1B. So this is a case 2, borrowed case, not my own case. This is a lady who had a post-bypass cardiogenic shock on admission, and you can see that clots moving in the right atrium. And this is a CT angiogram done, which shows that thrombus occluding on either side of the pulmonary artery, and you can see that flow retriever catheter there and the eyes there, and you can see that a lot of thrombi floating in the RA in the eyes imaging. And this is a flow retriever. Flow retriever is a wide bore device with 3 nitinol meshes, which is being pushed in to suck the clots. And you can see that the clots are so much that the flow retriever, in fact, could not suck it. So it had to be taken out along with the clots through the inferior vena cava. And you can see that this is the withdrawn out flow retriever. And this is the eyes appearance showing that there are no clots in the RA, and this is the angiogram. So this patient was also given cardiopulmonary bypass support, and these are the clots removed, and this is courtesy of my friend in Case Western University. And now, what are the learning points in the second case that we have? Mechanical circulatory support is extremely important because this is going to break the RV death spiral. But however, the ACC recommendation right now talks about using it as a bridge till we use a definitive therapy like a catheter-based therapy or a lysis or a thrombectomy. However, there is much more data coming now that supporting with the ECMO and giving anticoagulation therapy, waiting for 4 to 5 days many times without any additional therapy, they were able to wean off the patient of ECMO. These are the biggest advantages of providing a mechanical circulatory support. And so these are the guidelines, and the complications rates are going to be high with mechanical circulatory support. And this is the device that was used in this case that I displayed to you. And these are the various studies on catheter-directed therapy. You have ultrasound-facilitated thrombolysis, where the direct dose of thrombolysis can be less than the conventional systemic lysis. And this percutaneous embolectomy with the flow retriever in RA, we have the FLAR study which showed that there is a good data based on that, 106 patients, and what they found was the thrombus load was significantly less. So the complications are definitely high when you are going to push in a 2022 French device across the heart. We need to be extremely careful. So I think another 45 seconds or I'll finish by the time. So if this is the flow chart that I showed, anyway, coming to the conclusions, prompt initiation of anticoagulation therapy with suspicion whenever major pulmonary embolism suspected is ideal. Systemic dose lysis is life-saving in high-risk pulmonary embolism. However, with intermediate risk, it has to be a case-based decision. Early initiation is very beneficial. However, you can get sustained benefit up to 6 to 14 days. Catheter-directed lysis and low-dose lysis have been done, tested, but have not been proven to be, a class 1 recommendation in the guidelines, but it's life-saving. Catheter-directed thrombectomy is promising. It's very important that we have pulmonary embolism response teams in high-volume centers. Just like we have a heart team approach for CABG or a cardiopstic program, we also need to have a heart team approach for a pulmonary embolism, particularly where surgical thrombectomy also plays a major role. Thank you very much for your patient listening.